cystectomy. Obviously, there are arguments for open radical cystectomy. We have Gokul Kandaswamy, who's a fellow colleague. He's both an open and robotic surgeon. And the next presentation is looking at the case for open radical cystectomy. And some would argue old is still gold. If I could have Gokul's presentation up, please. And immediately after this will be my presentation summarizing the evidence.
Hi, my name is Gokul Kandaswamy. Many thanks to the organizers for this kind opportunity. I'm going to talk about the role of open radical cystectomy in the present era. I have no specific disclosures. My expertise is in pelvic oncology. We're going to cover quite a bit of things today regarding bladder cancer, cystectomy compared with robotics. We know the conventional indications for cystectomy, which is localized non-metastatic muscle-invasive bladder cancer, and in high-risk non-muscle invasive bladder cancer when BCG has failed. Not sure whether people come across the concept of very high-risk non-muscle invasive bladder CA. EAU started to classify this separately a few years ago, and this has evolved over the last few years. A couple of years ago, it used to be anything that is G3T1 with CIS, with lymphovascular invasion, qualified as highest risk or very high risk NMIBC. But as you can see now, even with TA disease, when they have a few other risk factors, then they become the highest risk NMIBC. And they have developed these three new additional risk factor criteria. It remains when you have variant histology, prostate urethral CAS, and lymphovascular invasion, they do get upgraded as the highest risk NMIBC. And in this category, upfront cystectomy is preferred rather than sending them for immunotherapy or BCG. Why is that so? We know because with the nomograms and with long-term studies that this cohort of patients have the highest risk of progression, and it is roughly 40 to 50% over a period of 5 to 10 years, which is significantly high, and hence upfront cystectomy is indicated. What's the biology of bladder cancer? It is different from other cancers, as you know, and especially muscle-invasive bladder cancer is not a localized disease to bladder. It has to be treated as a local regional disease, which means you need to have good cancer control, not just by removing bladder, but also lymph nodes. The importance of lymphadenectomy is beyond debate. It's well settled. And a lot of series, good number of patients have shown that even in a muscle invasive bladder CA, where the disease is confined to the muscle wall alone, you have a 10 to 25% risk of lymph node involvement. And as the T stage, pathological T stage increases, the lymph node involvement increases as well. Sorry. So if you do not do lymphadenectomy at all, which is the green line, you can see a significant drop in survival. And in fact, it is worse than people in whom there is actually a positive lymph node, which means by doing lymphadenectomy, you're probably potentially curing a patient with positive lymph node, and you're doing a much worse service by not doing a lymphadenectomy. And also in 2008, the CA database review has shown the importance of survival in lymphadenectomy in improving survival. And they even could come up with the number that when you retrieve more than 16 lymph nodes, the survival improvement is better than with other number of lymph nodes retrieved in specimen. And it is now considered as one of the quality measure for your lymphadenectomy. And you can see that the improved survival is sustained even beyond 10, 15 years. The 5-year disease-specific survival, when you compare and look at other cancers, it's significantly worse for bladder. When it is confined to the muscle wall, your 5-year survival is below 80%, and as the T stage increases, it drops below 50 and 40 and so on. On an average, we used to say, if you are counseling somebody for cystectomy with muscle invasive disease, the prognosis in 5 years from that point is survival is about 50%. If you put these parameters on nomogram, you can see how bladder cancer behaves, even a T1G3 disease, so-called high-risk non-muscle invasive bladder cancer, is as bad as somebody with Gleason 10, 12 out of 12 positive course, and with PSA of 75, and with clinically palpable extraprostatic disease. So it is much worse than what many people think. When it comes to surgery, what do you remove? In men, it's fairly standardized for a standard radical cystectomy. In women, way back in 2005, it's described that the anti-urethra should come out along with your specimen, but as you can see, there's no mention of ovaries or fallopian tubes, which is now considered as a part of standard cystectomy, but not urethra anymore. The rationale here is that there is a significant variation in what you should remove as a part of standard cystectomy, and with the era of neobladder and organ preserving, especially for sexual functional outcomes, these things do change. So what we remove depends upon these other parameters as well. But whatever we do, what cystectomy involves is, it is a surgery on multiple system, i.e. urinary tract, genital tract, bowel system, lymphatic system, and the metabolic system. Even in people who are having just a conduit diversion, there is some degree of alteration to the homeostasis, or the metabolic homeostasis. So it is one of the most complex surgeries performed, and hence morbidity is inevitable. There are some standardized quality indicators of how a prostate cancer surgery should be measured, but we don't have any in bladder, probably for the reasons we discussed earlier. But we can develop certain indicators, and any quality indicator should cover broadly all these areas. There's a survival data, the patient reported outcome measures, or the cancer survivorship data, quality of surgery, complication from surgery, etc., and also how good is your pathological specimen. And there's a special mention about lymph node status, so I put that separately there. Just going into lymphadenectomy a bit more detail, a good standard lymphadenectomy should cover all these areas there. So level 1 lymphadenectomy, or a standard lymph node dissection for bladder cancer, should involve external, internal iliac areas with obturator, sort of lymph nodes, area behind the major vessels, which is the fossa of Marseille. Presacral lymph node could be considered as a level 2 by some, but ideally should be part of your level 1 dissection. So this is the minimum lymph node dissection that you're expected to do. And there are higher levels of lymph node dissection described as well to be selected for appropriate patients. For people who are giving exams as part of your training, just be mindful that the definition of level 1, level 2 differs between prostate and bladder cancer. Now, why is this area of dissection important? We know 95% of positive lymph nodes will be covered or will be removed if you follow this standard template. Obviously, if you go higher up and do extended node dissection, you will get more nodes in the specimen, and also you will increase the chance of picking up positive lymph nodes when you have higher stage disease. So more the nodes, more the yield. That's quite obvious. What it means is that you're increasing the chance of picking up node positive disease, which means you're clearing micrometastasis as much as possible. And also you are making them eligible for adjuvant chemotherapy when you can pick up node positive disease, which should improve your survival. We know way back, this is roughly 15, 18 years ago, this was published to say that the commonest landing site is actually along the internal iliacs. And know from experience that is one of the areas which is commonly missed during dissection. If you look at mapping studies, you can even see lymph nodes quite higher up in a T2 disease. And as the T stage increases, the number of lymph node involvement and the proportion of nodes at higher levels go up as well. Does that mean we do an extended lymphadenectomy as a routine thing? Answer is no, we don't have the evidence yet. But the SWOG study, which is probably due for publication, should be able to answer that when it is out. This study randomizes radical cystectomy patient to standard and the extended lymph node dissection. And then we will have a 3-year disease-free survival data once published. So what are the parameters that makes difference here in lymph node dissection? To me, it is not a pure surgeon's performance, it's a pathologist's performance as well. The reason is that because as surgeons, we can control the area of dissection. So starting from the genitofemoral node, which is your lateral extent, clearing all the tissue from there, that's the bone behind, and their major vessels, and you go behind the vessels and ensure clearance. The fossa of Marseille, obturator fossa, and that is your internal iliac chain, and you go all the way up to the mesorectal fascia, and that ensures a good anatomical clearance in the boundary. Now, what happens after we remove the specimen is completely beyond our control. We know that for the volume of specimen we remove, we expect about 1.5 to 2 lymph node retrieval for each centimeter we retrieve. So we should be able to expect the number of lymph nodes according to the volume of specimen you remove. Do we have to send them in separate packets to increase the yield? That's something that's been discussed. But if you have taken care of the volume and the anatomical boundary, you don't have to worry about presenting them as separate packets as external iliac specimen, internal iliac specimen, obturator specimen, and so on. But a lot happens in the lab after it is sent to the lab. The way the pathologist dissect and retrieve lymph nodes is highly variable. Most of the time it is done by gross inspection and palpation. And we know by changing the way you do it, actually you can increase your lymph node yield. And in fact, even asking pathology assistants to do it, then the consultants themselves also increase their yield. Most of these studies are in colorectal. In fact, this has been extensively studied in colorectal CA rather than bladder CA. So that's one area where urologists could focus on for the future is about these sort of concepts where how to improve lymph node yield. And whether there is any association between high volume centers, the type of surgeons, particular pathologists, and so on and so forth. Next is how good is open and robotic at this point of time. This is the latest, best available evidence, the Cochrane review, which Bhavan did a couple of years ago, published in the database. Only 5 studies eligible for the evaluation, the 5 RCTs, the best of which is the RAZOR trial, which is the highest level of evidence so far. It's not a great number of patients that were eligible for this systematic review. And the most important thing is that all these RCTs report on patients who had extracorporeal diversion or anastomosis. Now, to me, that is quite counterproductive. There's no point spending millions on a kit and not performing an intracorporeal anastomosis. Of course, the IROC is going to address that issue, but until we have that data, we don't have a good quality data at the moment. Even among what we have, we don't see any difference between open and robotic. The main parameters that we adopt to measure as the quality of our surgery. The difference lies in minor complications where robotic fares better, and in transfusion rates. Of course, transfusion is important, but so that's the only area where robotic actually scores over open, the best available evidence as of now. Cost of these two treatments, traditionally we used to think robotic is costlier than open, but the problem with all these costing studies is it's so variable between different healthcare setups, so it's very difficult to compare. 2016, Hugh reported from C database that there's a $3,000 to $4,000 increased expenditure on the robotic cystectomy patients, but more than the operative cost, the health economic evaluation suggests that reducing the complication and improving the overall survival is probably the best form of making things cost effective. This is Nick Vasudev group who published this earlier this year. So if you take 2018-19 as a reference year, and if you look at the costs of these two treatment options, there's not a huge difference between the two, and it is the cost of readmission complication actually remains a huge concern. Positioning of the patient between the two approaches, I think you could try this for yourself. If you spend 5 minutes in hyperextension yourself, 5 minutes in Trendelenburg, street Trendelenburg, you will know how difficult you will feel after 5-10 minutes. So there are definitely some possible safety issues which is not fully well analyzed or published. Cosmesis is other thing that people talk about. The picture on the left is from Campbell Urology, where that's the description of an incision for cystectomy, which I don't completely agree with. Cystectomy is a true pelvic area surgery. You don't need to go beyond the true pelvis for all aspects of surgery, and hence your incision don't have to go all the way up to the umbilicus. I usually say an inch and a half below that level is more than enough. So roughly about a 12 centimeter incision is what we do. That's your ileal conduit procedure, and that's a neobladder procedure, and this incision size is fairly the same. As long as you can get one hand inside the abdomen, that's more than enough. Does robotic cystectomy equals small skull? Definitely not. If you just combine the length or the size of these incisions, and assuming you could need to have a couple of inches of incision to take the specimen out, you're probably looking at the overall length of these scars will be as big as open radical cystectomy. Ureteroenteric anastomotic stricture rates is something that's not very well described. There is a paucity of data, but from what we have, we know robotic approach is an independent risk factor. This is from a fairly large scale study published just last year. If you're a novice who is starting to do robotic cystectomy, just because your experience is low, that itself will is an independent risk factor for a stricture rate. And in fact, it's noted to be roughly about 47% in the first year. And in fact, even if you gain some experience, it doesn't get that better that quickly. Readmission rates, there's no difference between open and robotic approach. As mentioned earlier, this is one of the main criteria to reduce costs of surgery, but both are actually similar. But what's more important is when you look at patients who are getting readmitted, the reasons why they're getting readmitted remains fairly similar. And even the timing when they get readmitted after surgery is also fairly similar, and the proportion of patients getting admitted at different timings remain fairly similar. So there's no big difference between the two approaches. Positive surgical margin, the previous systematic review and meta-analysis before Bhavan's one in 2019 is this 2015 one, which has addressed this issue of positive surgical margin, wherein there is no major difference between the two. Bulk of the improved recovery after cystectomy is actually due to enhanced recovery program. Both robotic cystectomy and the concept of enhanced recovery came at the same time. So the open cystectomy actually also has improved a lot since enhanced recovery is implemented. So when you talk about cystectomy, the importance of enhanced recovery has to be acknowledged. And in fact, much of the robotic cystectomy improvement in outcomes is also attributed to enhanced recovery. 10 years ago, 40% of cystectomies in US were done robotically and 60% were done by open approach. The change is not that significant year on year. And in UK, as of 2018, we are still doing 40% of cystectomies robotically. So bulk of the cystectomies continue to be done by open approach. It really hasn't picked up as the prostate surgeries have picked up. We say roughly 90-95% of prostatectomies are done robotically, but the majority of bladder are done by open approach. And clearly, there should be a reason for this. The length of stay, robotic approach really hasn't made huge change. So there's probably a 3 or 4 day difference between open and robotic, as you can see, but that difference is sustained over that 5-year period. So if it is better treatment, and as surgeons get more and more experience, robotic approach should be able to demonstrate much shorter hospital stay. Again, it clearly hasn't. So how does an individual surgeon's data would look like? This is somebody who had done 400 plus surgeries in a 10-year time, which is roughly what an average UK cystectomy surgeon would do. In the first few years, you obviously select patients who are less complex, and you can see the only significant difference is in the study is people who are having surgery at the later part of the surgeon's career and experience is he takes up higher complicated cases and patients with poor performance status. Now that actually translates into higher morbidity and in the 90-day morbidity scale, clearly showing that it is the patient parameters which is more relevant than actually surgeon's experience as such. Group of cystectomy surgeons joined together in 2015 and came up with this consensus statement regarding their expected outcomes when they perform, whichever approach you adopt for. There are quite a lot of parameters which are fairly important in cystectomy. The long-term complications, because this is a significant factor in their survival. cost of treatment, etc. And these things are not very well studied. This probably is a case selection bias, which we actually saw in a couple of slides ago with robotic cystectomy. And if you start doing more complex patients, your results probably may just start to match open cystectomy than show any superiority. We don't have strong lobbying and public patient involvement for bladder cancer treatment. So that's an area for us to improve on. And from training aspect of robotic surgeries is highly a fellowship-based training, while open cystectomy can be part of your core training. And in fact, I can say in Wales for the last 5 years from our center, 4 of the SPRs who passed out are pelvic surgeons without doing any fellowships. Finally, what does EAU say is it's not the approach that's key, it is the surgeon's experience and the centralization and institutional volume that determine the outcome rather than whether it's open or robotic. So in a nutshell, bladder CA is actually a much worse disease than many think. And people who actually go for cystectomy, it is probably the only shot they have at cure. Because if that fails, there is no effective treatment following that. So if you consider that, open surgery remains as a gold standard and probably will remain so until we have some very good quality evidence. Robotic approach is good probably for a selected cohort, but it's not ready for the prime time to replace the open approach as of now. Finally, this is not Formula One, where the machine is 95%, and the role of man behind that machine is only 5%. But in cystectomy surgery, it is the surgeon who is more important than the machine itself. Thank you for the opportunity.
Thank you very much, Gokul. That was an excellent presentation and some very strong arguments in favor of open radical cystectomy. The next presentation is a summary of the evidence that I have prepared. And